Bismillah ar-Rahman ar-Rahim. The topic of today's discussion is pediatric GIT bleeding. GIT bleeding is a common problem in pediatrics. These are the cases which we are going to entertain in the OPDs and in the emergency rooms at time. The objectives at the end, the objective to be achieved, that at the end of the session, the student should be able to understand the basics to the GIT bleeding. They should be able to list the causes of bleeding by age groups. They should be able to explain some details of the more common clinical causes. They should be able to list few uncommon causes also, and be able to explain the basic diagnostic approach. The flow of talk in this session would be under these headings. It is not necessary that the sequence will be followed exactly as the way this is being shown. Now, it would be very appropriate and important at the same time to look into some of the cases whereby these children tend to present to the physician. Now, the first three are of the neonatal age group. The first one is a 5 years old healthy boy who has been feeding well, and the mother complains that she has noted blood in the vomitus, and she also complains that she has some pain during breastfeeding. The second case is a 7-year-old girl. She was a home delivery. She was being breastfed exclusively, and now she has passed fresh blood in the stool on 2 different occasions, 12 hours apart. The third scenario is of a 2 days old unwell child who is not feeding well, and the vomitus contained coffee ground colored material. These are relatively older children. The first is a 4-year-old who has severe constipation of recent onset, but he has passed stool with some difficulty, and a streak of blood has been noted in the perianal area. The second is a 3 years old child who has fresh blood in the stool, and this is happening off and on. And there is some complaints of, and there is additional complaint of something coming out during the act of defecation, and there are no other complaints. The 4-year-old who has presented off and on with painless, significant bleeding in the stool, and apart from pallor and anemia, she doesn't have any other findings. The last one is a 7-year-old who has a history of liver disease, now has developed ascites and splenomegaly, and this child has passed fresh blood, and there's a history of melena also. Before we proceed further, the few terminologies need to be looked into. The first is hematemesis, and hematemesis basically means fresh blood in the vomitus, or that can be of a coffee ground color. The coffee ground vomitus is due to the action of hydrochloric acid, which is in the stomach, on the blood, and it changes the texture and color of the blood. Melena is the passage of loose black tarry stool with a characteristic foul smell, and hematochezia is basically passage of fresh blood per annus. Usually it indicates bleeding from the lower GIT, but can occasionally be the presentation for a brisk upper GI bleeding. Or if the transit time is short, fresh blood will appear in the stool also. So, the presence of frank blood in the vomitus usually suggests a more active or severe bleeding as compared to coffee ground emesis. The lower GI bleeding classically presents with hematochezia. However, bleeding from the right colon or the small intestine can present with melena. Bleeding from the left side of the colon tends to present with bright red stools, whereas bleeding from the right side of the colon often appears dark or maroon color, and it may be mixed with blood. Now, this is an important slide It tells us about the ligament of Treves, and any bleeding proximal to the ligament of Treves is upper GI bleeding, and below this area, below this ligament, is the lower gastrointestinal bleeding. So that's the line of demarcation. The characteristic of bleeding, we've already talked about that. Hematemesis is the vomiting fresh blood, and coffee ground is when it is small and there's a delay in the vomitus, and the acid of the stomach acts on the blood and it changes to coffee ground color. This is black tarry stool, and this is melena. At time this is fresh blood, so hematochezia. These are some of the pictures showing the esophagitis. These are esophageal varices. This is a candida esophagitis. Now, the practical way of dealing with these children is, the first and foremost question is, when there's hematemesis or blood in the stool, is the first we need to ask is it really blood? Because at times red color can be imparted because of consumption of tomatoes, strawberry, beetroot, food color gelatin, and the melena can be because of bismuth, which is present in some of the antidiarrheal diseases. Iron preparation imparts a blackish color to the stool, and spinach, blueberries, and charcoal can also give the stool a black color, uh, creating a confusion that this could be melena. Three important things that also need to be looked into: the vomitus or the melena. Is it really coming from the gastrointestinal tract, or it is coming from the nasopharynx in the form of epistaxis or as a naropharyngeal mass? Is it hemoptysis, means blood coming uh, from the lungs, or is it really coming from the stomach? Is there any contribution by the oropharynx in the form of interdental papillae or gum erosions or swollen gums? Is the blood coming from the gastritis, H. pylori infections, gastric varices, and fundal polyp? Now, the etiologies of upper gastrointestinal bleeding by age group is a practical way of considering these hematemesis and melena. And these are also listed in an order of frequency. Like in a neonate, a baby can actually swallow the maternal blood, and that on vomiting will be like coffee ground like or fresh blood. Vitamin K deficiency causes hemorrhagic disease of the newborn. Stress, gastritis, or ulcer can happen with medication as well as with stress of infection. Esophagitis can be because of candidal infection. There could be trauma which can be induced by nasogastric tube placement. Vascular anomalies like hemangiomas in the mucosa of anywhere from the esophagus to the stomach. Gastrointestinal duplication, there are congenital abnormalities of the gut, small gut. Coagulopathy associated with infection in the form of GIT and stress ulcers. Cow milk protein allergy is a relatively common entity to present with hematemesis as well as fresh blood in the stool. And congenital coagulation defect in the form of hemophilia, factor IX deficiency, Christmas disease, and so on and so forth. Stress or gastric ulcer is the one in which the children can be really sick. And then we can have peptic disease of H. pylori infection, of duodenal ulcer or gastric ulcers. Mallory's tear happens in the condition where you have forceful and severe retching, resulting in tear in the mucosa of the esophagus or the gastroesophageal junction. Various vascular anomalies already talked about, and bowel obstruction. They all can contribute in an infant. In the relatively older child, the etiologies are more or less the same with slight reshuffling of the causes. This is the same list. I just put it for the students to be able to uh, facilitate their learning or to memorize them. I'm sorry for the quality of the previous slide. The most common diagnosis to consider in newborn presenting with lower GI bleeding are swallowed blood. Now, how do we determine whether it is maternal blood or is coming from the baby? There you have the apt Downey's test, and it detects the fetal blood, which reacts differently to an alkaline reagent versus the adult blood. Anorectal fissures, it happens with severe constipation normally. And you see, these are patients who are really very sick. They are also very sick patients. Then you can have coagulopathy, you can have gastric duodenal ulcers and GI duplication cyst. We can have rectal ulcers. We can have amoebic ulcers, not in the newborn period, but well in the older children, they are the reasons for blood in the stool. Causes of bleeding in infants and toddlers are more or less the same with slight changing the position. Anal fissures, cow milk protein allergy, induced colitis, and intussusception, GI duplication, and Meckel's diverticulum are some of the causes of GI bleeding in the relatively older age. Now, what we do once we get a patient with such bleeding episodes, we have to have a very focused history. Is it really bleed? We already talked about it earlier. Is it hematemesis? Is there anything else contributing to the color? Is it not hemoptysis? What is the age of the patient? Because we have looked into the list of the diseases age-wise. Any other source for this bleeding? What is the magnitude and duration? Is it sudden or gradual in onset? What is the level of bleeding? Fresh blood, vomitus, upper GI bleeding, fresh blood, lower GI bleeding, fresh blood coming from proximal to the ligament of trees, and if it is profuse, so it will also cause fresh blood in the stool and color and the amount of hematemesis and malaria. Now, associated GI symptoms like pain and tenderness in the epigastrium would favor the presence of duodenal ulcer or gastric ulcer. Vomiting, which is repeated and forceful, if there's regurgitation and retrosternal pain, Mallory-Weiss syndrome, and reflux esophagitis can be the underlying cause. Anorexia, nausea, vomiting, relation to food, diarrhea, and dysentery. Diarrhea and dysentery can also be contributory to if we have lower abdominal pains and cramps. Associated symptoms in the systems like fever, rash, joint pain, and dizziness and palpitation. We can think about vasculitis, HSP, and other connective tissue disorders. History of non-steroidal anti-inflammatory drugs, steroid, iron consumption can cause gastritis and can cause hematemesis as well as black stools. The risk for portal hypertension would be a history of umbilical sepsis or umbilical catheterization and jaundice off and on and chronic liver disease. This is more comprehensive list of the key symptoms in the history as contributing to the cause of the if there's sudden onset and massive hematemesis, it will be more compatible with a vascular bleed from the varices or other arterial site. Vomiting preceding hematemesis is usually with small bleed, but it could be Mallory-Weiss tear, esophagitis, or gastritis. The characteristic of stool: epigastric pain or heartburn, gastritis, peptic ulcer or esophagitis, vomiting and feeding intolerance. There could be many causes, including cow milk protein allergy and peptic acid peptic disease. Odynophagia, which is pain with swelling. It could be esophagitis, could be foreign body, candidial infection, or CMV infection. Jaundice would be a marker of an prolonged liver disease. Epistaxis, recent or recurrent, would be resulting in ingested blood from the nasopharynx or bleeding. Easy bruising or bleeding, bleeding disorder, which will be referred separately. Underlying disease. If there's a chronic liver disease, can cause various vascular problems. Bleeding disorders like von Willebrand disease, ITP, liver disease, vitamin K deficiency, critical illness, risk factor for peptic gastritis, esophagitis, or ulcers. Medication, tetracycline, normally we don't use in children, but any child for over 8 years can take tetracycline, or if he's taking, or the patient is on non-steroidal anti-inflammatory or bisphosphonates, then they could be the reason for this bleeding. In the other history, breastfed infant, swallowed maternal blood would be one possibility. History of choking episodes prior to the hematemesis would point towards the presence of a foreign body, and severe cough, dizzy chest all the time. Then one has to decide whether it is hemoptysis or is real hematemesis. I would skip this, but I just would like to the students to look into it. That it summarizes what we have already talked about. Now, after we have considered the possibility of the cause or the etiology of bleeding, what do we do? The initial assessment and stabilization. First and foremost would be ABCD, airway, breathing, circulation, and checking the sugar of these patients with significant GI bleed. We have to assess the degree for rapidity of blood loss. The vitals will help us in deciding that. Means heart rate, respiratory rate, oxygen saturation, capillary refill time, urine output. Orthostatic blood pressure changes can point towards moderate to severe blood loss, and presence of shock would be tachycardia, decreased urine output, pallor, sweating, confusion, or obtundation. Clinical features suggesting a severe upper GI bleed would be melena or hematochezia, heart rate more than 20 beats per minute above the mean for heart rate, about for the age, prolonged capillary refill time, decrease in hemoglobin concentration for more than 2 grams, need for IV fluid boluses, need for blood transfusions. Investigation to begin with are very simple: CBC, PT and APT. CBC for the degree of anemia, means the hemoglobin level, hematocrit. PT for extrinsic pathway, APGT for intrinsic pathway. LFT is for the possibility of a chronic liver disease. Blood group and cross matching has to be done because we may need blood transfusions. Further investigation is determined by the type, severity, profuseness of the bleeding. Ultrasound for liver architecture, ultrasound for portal vein will help us in deciding portal hypertension. Endoscopy would directly visualize and is a procedure of choice in the upper GI bleeding, but the caveat is that the patient has to be hemodynamically stable. If an endoscopy is not helping, the second option would be a CT angio to pick up the malformation beyond duodenum. Nuclear scintigraphy is where radioactive substance is injected and it traces the site where from the bleeding is taking place. Again, the limitation is you have to have at least 0.1 ml per minute of bleeding. Angiography, superior and superior mesenteric artery angiography helps in deciding the vessel where from the bleeding is taking place. The management is supportive and specific. The supportive treatment is ABCs again, checking the volume status, placing an NG tube, aspirating and calculating the amount of blood that is being lost. If needed, the component of blood like different factors, plasma, FFP, cryoprecipitate transfusion, and decide whether the patient is hemodynamically stable or is unstable. The unstable signs we have already discussed. Specific treatment and the variceal bleeding is beyond the scope of today's talk, so that we'll be leaving for next time. So in summary, the upper gastrointestinal bleeding is a potentially life-threatening emergency requiring an appropriate diagnostic and therapeutic approach. Therefore, a primary focus in a child with upper GI bleeding is resuscitation and stabilization, followed by a diagnostic evaluation. In infant and toddlers, mucosal erosion is the common cause, whereas in older children, variceal bleeding due to extrahepatic portal vein obstruction is relatively more common. Upper GI endoscopy is accurate and useful diagnostic tool to evaluate upper GI bleed, and the treatment depends upon the cause. Now, the case scenarios that we have already discussed, the answer are put forward now. This is the patient with cracked nipples, the patient with hemolytic hemorrhagic disease of the newborn, sepsis, anal fissure, was a patient with rectal polyp, patient with Meckel's diverticulum, and patient with portal hypertension. To summarize again, this is a simple algorithm. If you're suspecting an upper GI bleed, you want to decide whether the clinical assessment, history and clinical examination, and initial resuscitation if is compromised. Initial pre-endoscopic risk assessment have to be done, whether the risk of rebleeding is there, because this patient will be needing more urgent endoscopy and ICU admission. Whereas if it's a less risk of pre-bleeding, the patient can stay in the ward, and a planned endoscopy or colonoscopy can be undertaken. Esophageal or gastric varices, ulcers, polyp, AV malformation, and mass or other things are possible things which we can pick up on colonoscopy and gastroscopy. If no source is found, the more sophisticated tests have to be done